our colleagues who have joined in our monthly Society of Surgeons meeting on Zoom uh, from Karachi. Uh, we are privileged today to have two international faculty joining us, Mr. Ling Wong and Mr. Adil Ahmed Bajwa. Both are eminent colorectal consultant surgeons from University Hospital, Coventry. So, Dr. Wong and Dr. Bajwa, you're very welcomed in our meeting. The session is in a manner that medical staff residents generally present cases which they think are interesting, and generally we offer comments. With this session will be moderated by Dr. Madhia Ali. Uh, and with this, Sabha, would you want to say a few words, because you were very critical in organizing and getting our two eminent speakers to be part of this meeting?
Yes, I would also like to welcome both the consultants. They took special time on their off day and they joined us to interact with us. Very warm welcome from my side.
Oh, thank you. Yeah.
So Mr. Wong and Adil, with your permission, shall we start?
Yeah.
Yes.
Thank you. Thank you for your invitation. It's a privilege. I'm here, Hasnain. I'm here to learn. I know you got very interesting case, probably a case that we've never seen before in UK. I hope our comment is helpful. If not, I'm here to learn from all of you. I'm just a general surgeon, well, colorectal surgeon. As you know, I do a bit of traveling. I haven't been, of all the places that I went to, I haven't been to Pakistan yet. I went to Bangladesh, I went to India, but not Pakistan for the MRCS and FRCS exam. But I'm here today to learn from all of you.
Thank you very much for those kind words. Sometime soon in future, we will be inviting you in one of our conferences.
Thank you.
And obviously, and the whole idea is to present the situation as it is, which may or may not be ideal, but definitely it is different. But the principles remain same. So, Dr. Madhia, why don't you take over?
Good morning and good afternoon, everyone. Welcome to the meeting. So we have 4 interesting case presentations from our residents across the city. The first presentation will be by Dr. Mehreen, who is a resident, a postgraduate trainee in surgery from Civil Hospital. And Dr. Mehreen, can you start your presentation now?
So just for our guests, Civil Hospital is one of the biggest public sector hospital in Karachi, and it is one of the oldest also. It's a very, very busy place. The attending surgeon could not be here because she's traveling right now. They have a very good colorectal unit, but obviously we have resource constraints given the number of patients that they manage. So Mehreen, go ahead.
Assalamu alaikum. I hope everyone's having a good day. I will just share my screen. Sorry. Can everyone hear, see my screen?
Marine, we can't. Marine, are you trying to share your screen?
Yes, sir, I am. I don't know what's the issue.
So Madhya, if you have her presentation, can you share and run it for her?
Sure. I'll try and do that. She's sending me the presentation again. I'll check if I have a copy with me. Is my screen visible on the?
Madhya, can you just hold on for a minute because this is not, it won't be right then.
Okay, I won't share it if that's what you wish to do.
Marine, can you email the presentation to Dr. Madhya?
Salmana.
Yes, yes, sir, I'm doing that just now. There seems to be
Madhya, also, can we, while we do this, can we move on to the next presentation?
Usman, are you here in the meeting? If yes, please start your presentation. Usman. I've asked the next presentation presenter to start his presentation. He'll be joining us and starting his presentation.
Adil, would you want to present first, you think, while the technical issue being sorted by the team in Karachi? What do you think?
Yeah, I think while we are trying to sort it out, that's a good idea. Let's not waste time anymore.
Yeah, just wonder. I know it's a technical issue. It happened all the time.
Yeah.
Don't worry, Hasnain, we understand. But I think, Adil, probably you got all the presentation ready, aren't you?
Yes.
Thank you so much. I think it might be useful. Sorry, Hasnain, I wasn't trying to interfere. I thought.
No, this is fine, I think.
So I don't know, I hope you can see my screen.
Yes, we can. Thank you.
So, well, firstly, thank you for inviting me. Assalamu alaikum. My name is Adil Bajwa. I'm a colorectal surgeon in Coventry, University Hospital, Coventry in Warwickshire. I work with Mr. Wong. And I've been asked by Saqib to talk about extralevator abdominal perineal excision. So in my opinion, one of the biggest challenges in colorectal cancer surgery is male rectal cancer. And the reason is the male pelvis, unlike the female, is very narrow. The views are limited, either from the abdomen with either open or a standard laparoscopic approach. And you can see that in the CT scan on the right. You've got a mid-rectal cancer. You can see how it's plugging the inlet of the pelvis. So you can imagine how difficult surgery is. There's no views, there's no space really. This is a picture of Professor Bill Heald, who's a retired surgeon in Basingstoke. And he demonstrated that outcomes in rectal cancer surgery are greatly improved if you dissect in the correct anatomical mesorectal plane called the TME plane. With TME surgery, the rates of local recurrence are very low. And this is achieved because you get clear margins which we call circumferential resection margin. So we know that with TME surgery, the circumferential resection margin negative rate is higher, and this in turn reduces your rates of local recurrence from 22 to 5%. However, even after the TME era, there remained a problem with standard supine APR with very high rates of local recurrence. So in order to improve these outcomes for APR, there was a Swedish surgeon, Torben Holm, in 2007 described a new technique called extralevator APR. And this basically involves an extended perineal dissection while the patient is in prone jackknife position with en-bloc removal of the levator muscles. And that leaves you with a cylindrical specimen with better clearance, reducing the risk of CRO involvement. And because the visualization is better, the risk of perforating the rectum is less. And it's a very simple approach. The principle is to stop the abdominal dissection above the pelvic floor, and then to turn the patient prone and dissect close but outside the external anal sphincter in an easy to identify surgical plane. The plane outside the external sphincter will lead you to the extralevator plane higher up, when the sphincter will merge with the pelvic floor. The levators can then be cut, if need be, close to the bony pelvis to allow you to join up with your abdominal dissection. And it's clear to see why this is better when a low rectal cancer is invading the levators. It's obvious that if you stay on the other side of the levator, you will avoid dissecting close to the tumor. And this in turn means that your specimen is different. Instead of having a wasting, we call it a wasting, where you have a narrowing close to the tumor with a standard APR. With ELAP, you get more of a cylinder type rectal amputation. But ELAP should also be considered, in my opinion, for any low rectal cancer, even if the tumor is confined to the bowel wall and not involving the levator. In essence, if the cancer is too low to staple below for either an anastomosis or a low Hartmann's, then you should consider an ELAP. And in practice, this means if you've got a tumor that's 3 to 4 centimeters from the anorectal junction, realistically, it's going to be very difficult to staple below that. So in those patients, you should consider perhaps doing an ELAP. And the main advantage of ELAP is that it greatly reduces the risk of rectal perforation, which is quite common with a supine APR or if you're doing an intersphincteric dissection. And this is especially the case in male patients. And we know that if you perforate the rectum during rectal cancer surgery, because of tumor seeding, the risk of local recurrence at least doubles, which in turn will reduce long-term patient survival. And this is data from a big Swedish population registry. And now there is plenty of evidence that with ELAP, the rate of rectal perforation drops. This was a multi-center European study. You can see that the rate of intraoperative perforation with ELAP dropped from a very high 28%. So just think about that, 28% rectal perforation with supine APR in expert centers in Europe. That dropped to just 8% with ELAP surgery. There is a cost. And the main cost is that your perineal wound complications double. And you'll see that in the subsequent slides. The surgery itself, I think, is much easier than supine APR. The dissection starts outside the skin markings of the external anal sphincter, which are easy to see. This is a Lone Star retractor, which is a single-use device, but you can use any retractor. And the key thing is the plane outside the external sphincter. It's very well defined. It's very easy to find, and it's avascular. Typically in a man, the tip of the coccyx is also excised. Again, this is very easy to do because the bone is very soft. You don't need to find the joint. You can just go through that with you know, any bone nibbler, and that gives you great access. And really the key benefit is excellent exposure of the anterior plane between the rectum and the prostate. This plane is very difficult to dissect in the supine position, and with ELAP, you know, it's exposed very clearly, and it makes that part of the surgery a lot easier. This is a case I did earlier on this year. This is a salvage APR for anal cancer, post long course radiotherapy. The patient had, I don't know if you can see this very large fungating anal mass. And this is the post excision picture. You can see how large the defect is. Now, in the UK, we tend to repair the pelvic floor with a porcine biological mesh. I mean, I can understand why that might be an issue in Pakistan, but you could do the same with the vicryl mesh. Or, you know, if the defect isn't too big, you could perhaps even do a primary suture repair of the pelvic floor. But you can see how the prostate is exposed, and you can then, you know, you can appreciate how much easier that dissection is. If you can see the prostate and the rectum, that plane becomes a lot easier to dissect. And it's really this plane between the prostate and the rectum that is, you know, the big challenge in rectal cancer surgery, because it's hidden behind the pubis and the bladder. There's no views from the abdomen, and ELAP helps solve that problem. But just to finish off, just to giving you a UK perspective, we're now solving that same problem in a different way with robotic surgery. And that's because the robotic mechanical traction, you know, enables excellent anterior views because of the, you know, the robotic traction. And this allows a very accurate dissection anteriorly all the way down to the intersphincteric plane. This is the same patient. You can appreciate how little space there is, but it's the robotic traction that exposes the plane. This is the pelvic floor on the side. And you can see how you can get accurate TME dissection. Same patient on the other side. Limited views until the mechanical arms come in. The robotic arms will retract underneath the seminal vesicles, and you can expose the pelvic floor. And what this is allowing us to do is to push the boundaries, staple below tumors that are very close to the anorectal junction. This is the CDH gun coming through. I think this is the same patient, and we'll be able to dissect all the way down to the pelvic floor. Thank you for listening.
Thank you, Dr. Adil, for excellent presentation, and the robotic view was really beautiful. The concept is excellent. I will open the floor for any clarifying questions that audience may wish to ask.
Hassan, can I ask whether the ELAP is practiced in Pakistan? Is it a routine procedure you do for low rectal cancer?
In Pakistan, there are variations. I see our surgeons from public sector. I will ask them to respond to this question. But in our hospital, it is practiced to a limited extent. It is something which we don't practice routinely.
Okay. Does the pathologist take a picture of your specimen like the one that Adil did? I mean, we get criticized in our MDT meeting if there's a significant wasting in the specimen. So our specimen is scrutinized.
Yeah.
There's a lot of quality assurance in the way we do the surgery. I just wonder how Pakistan, just for my interest really.
So there's a lot of after Professor Bill Hales, there's a lot of awareness of importance of TME and plane, and generally people kind of talk about TME, but the way it is evaluated from pathological end is kind of little lacking, and maybe that is one of the reasons why I can't say with certainty that we practice ELAP in that sense. And so probably the way the quality is driven in your country is through an independent process, which is a pathologist giving comments uh, on the specimen and directing surgeons who maybe next time focus better. That is something that we need to incorporate. But obviously, I can only speak for my institution. Raza has raised his hand. Raza is a brilliant surgeon focused on cancer surgery. Maybe I would ask Raza to comment on what is happening here.
Thank you.
Thank you, Dr. Stan. I can't say what's happening elsewhere, but for in my practice, and I work at Patel Hospital, all of the lower rectal cancers I manage with an extra-elevator APR in a prone jackknife position. The defect is a problem in management, especially in low resource settings. And we don't always have prosthetic, the biological mesh available. When it's available, it's very expensive. We do resort to placing transposed omentum over the perineal defect, and then using sometimes using a simple proline mesh. I sometimes darn it with PDS. Have gotten away without any perineal herniation so far, and I follow my patients closely. So, but it's definitely not a fail-safe mechanism, and I'm aware. But I do select defects that are amenable for that. I just wanted to ask first. Thank you, Adil, for this presentation. Just I wanted to ask, what would be your approach and advice for patients who have a really thick mesorectum that or maybe large tumors that doesn't allow the specimen to be somersaulted out of the perineal defect for this anterior dissection, because that's something that we really get in trouble with, especially in males who are obese, have a bulky mesorectum and a really narrow pelvis.
Yeah, well, that's the big challenge of rectal cancer surgery. I mean, we're spoilt in the UK, and those patients, obviously, we are now doing these cases robotically. So we will always be able, with the robot, you can always get to the pelvic floor. You know, it's really revolutionized our practice. But, you know, occasionally we have to do these open, and then it's just about, it's the same principle. You've got to dissect in that anterior plane wherever you can see it. So if you have adequate retraction with the St. Mark's retractor from the abdomen, keep going. Otherwise, it's difficult. I mean, I sometimes go on the other side of the transverse perineal from the perineal dissection, because that's quite a good plane, and just do it from the perineal side. But obviously, the higher you get up, it is difficult. So I don't think I've got a magic solution for that, I'm afraid.
I suppose a big tumor, you will shrink it down with radiotherapy first in Pakistan.
Yes, yes. Sorry, all of the colorectal cancers get neoadjuvant therapy.
Yeah. Okay. Thank you.
I think one thing to say about that is that we are seeing, you know, good responses to this. So maybe Ling would know, maybe a quarter of our patients will have a complete response to the long course radiotherapy.
Also, excuse my ignorance, the patient there, are they big people compared to the British in terms of
No,
the
I think
size?
they are about same.
Oh, same. Okay, thank
Yeah.
you.
But generally
I would
tumors
say
are
the
advanced.
pelvises are much smaller.
Okay, so can we move on? Marine, are you ready now?
Yes, sir.
Okay, so I think we can move on to the next presentation. Thank you, Dr. Adil.
May I request the presenters to start with their presentations? And Mehreen, are you able to screen share your presentation now?
Dr. Adil will have to unshare his screen first. Marine?
Osman, can you start your presentation, please?
Yeah, sure, I can start my presentation.
Whoever, I'm not sure if, okay, so this seems, Mehreen, are you here?
Sorry
can't
about
hear you.
that. I'm incredibly sorry, everyone. I think I'm ready now.
Okay.
Bismillahirrahmanirrahim. Hopefully, good day to all. My name is Dr. Marine Ansari, and I'm a PGY 3 trainee in Surgical Unit 1, Civil Hospital, Karachi, under Dow University of Health Sciences. Today, I will be presenting a case of my patient. He was a 48-year-old male laborer by profession, married with 3 children, denying any comorbids. His ECOG functional class was 1. He presented in our OPD with complaints of bleeding per rectum, lower abdominal pain, altered bowel habits since 6 months, with weight loss that he appreciated in the last 2 months. He denied any addictions, any homosexuality, or family history of cancer or communicable diseases. He, however, did have a positive history for multiple blood transfusions owing to chronic anemia. On examination, he was a middle-aged male, well-oriented to time, place, and person. On systemically, it was anemia positive. The rest was unremarkable, no koilonychia. His cardiovascular examination and chest examination were unremarkable. His abdomen was soft, non-tender. There were no palpable masses. On digital rectal examination, we could see external hemorrhoids at 7 or 11 o'clock. However, he was too tender on digital rectal exam to proceed for proctoscopy, so it was not done at that time. We decided to proceed for flexible sigmoidoscopy at our hospital, which showed a polypoidal growth at 15 centimeters from the anal verge, which you can appreciate in the second image in the middle. And the scope was easily negotiated up to descending, and biopsies were taken at the time. Features of histopath favored moderately differentiated adenocarcinoma. We also went for CEA levels, which was 0.75, that were below. We decided to go for a CT chest, abdomen, pelvis, which showed a polypoidal soft tissue density arising from the right anterolateral wall, approximately 13.5 centimeter from the anal verge. It was about 4:3 in axial dimensions, with increased vascularity and perirectal fat stranding. A few small regional lymph nodes could be appreciated in the mesorectal fascia that was 0.3 centimeter or less. There was also a thickening at the junction of sigmoid and descending colon, length about 8.2 centimeters with maximum thickness 1.8 and some periregional fat stranding. There was thickening of pelvic peritoneal reflection as well as enhancing periregional lymph lymph nodes measuring 0.9 centimeters or less. So here I'm sharing the axial images of the CT scan. So this is anterior, this is posterior, right and left. You can appreciate the rectal lesion arising as an intraluminal defect within the contrasting rectum, where if everyone can see the star, it's we can see that it's arising from the right anterior lateral wall with some fat stranding and some lymph nodes. Apart from that, this is again axial cuts going a bit upward, and we can appreciate at the junction of the descending and sigmoid, there is circumferential mural enhancement with significant luminal narrowing and significant periregional fat stranding with lymph nodes that can be seen. And if you can, if everyone can see the red arrow, then this is the thickening of the pelvic peritoneum that they were mentioning in the report. We could also, in our axial cuts, appreciate a circumferential mural enhancement in the ascending colon, which is not causing luminal narrowing, but there is mild fat stranding associated with it. So just for the audience, I would like to ask, so what should have been the next step for us? Or I can just move on.
Marion, can I just ask me again, just forgive my ignorance, why flexible sigmoidoscopy rather than colonoscopy? Is it the routine practice in Pakistan because of resource limitation? You only organize a sigmoidoscopy?
So initially, even when we were examining the patient, he was being so uncomfortable. So initially we do proceed for first flexible sigmoidoscopy to rule out any, our assumption was that he could have had hemorrhoids or so forth. So we did go for first flexible sigmoidoscopy.
Now that you found a lesion in the flexible sigmoidoscopy in the rectal sigmoid junction at 15 centimeter, is it not a routine practice to proceed to a colonoscopy under sedation? Just
so after getting the non-invasive investigation, which was CT scan, and then we found these lesions, we then proceeded to go for colonoscopy.
Okay.
So we went for colonoscopy to check for any synchronous lesions, and we found two more lesions. One was seen at the descending colon, and the other was seen at the ascending colon at the hepatic flexure, where again biopsies were taken. And in the ascending colon, the mass would be moderately differentiated adenocarcinoma as well, while the descending colon mass was just fragments of colonic mucosa with mild non-specific inflammation, and it was negative for dysplasia or malignancy. So again, my question would be, what should be our next step? Or I can just move on.
Are you able to check for mismatch repair deficiency for Lynch syndrome?
At this point, no, because also it's not available in our setup.
But that's
yes,
maybe
I think Mr. Bhadwat, the resource limitation and yes, we have less inclination towards genetic testing for all patients unless we have a very specific family history or young patients. Then we, like the way we do for every patient here in Pakistan, generally we don't do mismatch repair deficiency test. If the practice has changed, so any of my colleagues can comment on that.
It's available on MSI by immunohistochemistry in a few pathology labs, but I'm not aware of it being done by PCR in any places so far.
Okay. Mary, can I clarify? There's no family history here of.
Sir, no. Yes, he denied any family history of any cancers or any bleeding PR as well.
I find the thickening in the descending colon, the stricturing lesion you mentioned, and the biopsy is not diagnostic of cancer. It's fascinating because there's no suggestion of ischemia was there in the history. or there's no non-specific information. So did the pathologist think this is ischemic or this is, you know, infective, causing some stricturing? I mean, there's a growth there, you say, but it's non-specific information. This is fascinating to me. Yeah.
So what should be? What? No, sir, he denied any history of any cardiovascular events or any even sort of, no angina, no, nothing.
And also there's no history of diverticular disease in the history there. So
no, sir.
It is very interesting. I think we can't ignore this one, but let's carry on. Yeah, thank you.
So again, what do everyone think we should have done at this point? Or should I just tell everyone what we did?
So since nobody is commenting, why don't you go ahead and tell us what you did?
So we got an MRI pelvis with contrast, which again showed a circumferentially enhancing thickening in the distal anal canal and the proximal rectum. And this was bulging into the perianal region. Maximum thickness along the left lateral wall was at 3 o'clock, approximately 4 centimeters in length. There was adjacent fat stranding. And as well, there were 2 peripherally enhancing hypodense lesion collections, which was seen in the perianal region. Some locoregional lymph nodes, largest 0.8 by 0.8, and there was no mesorectal fascia involved. So if I'm sharing my post-contrast enhancing images, axial cuts, we can appreciate this golden star here. You can say this is our lesion that they were mentioning. It's completely contrast enhancing, as well as the peripherally enhancing 2 hypodense lesions that they were mentioned as well with the red star that I've marked. As well, and associated with this was a thickening along the lateral wall, if you can see the cursor. So keeping this in mind, what should we have done next?
So Marian, how many cancers you have identified? You have identified 1 in the rectum, 1 in the ascending. My apologies if I have missed something, and one, 2 cancers and 1 suspicious stricture in the descending colon as well, in the entire colon, if I'm not wrong.
So there was the rectal polyp, the rectal lesion, then there was the descending colon, the fat stranding, which biopsy was inflammatory or infective.
Yes.
And there was the ascending colon, the hepatic flexure, at the hepatic flexure, which was positive for moderate differentiated adeno. And this thickening that came out in the MRI pelvis that we did.
Okay, and we haven't got the biopsy yet. Have we done the biopsy of this?
So of this particular, no.
Yes,
so
yes.
So our next step, sir, was that we decided to go for, we discussed in our tumor board meeting with our radiologist and oncologist, and we planned for a examination under anesthesia and biopsy, and also to get a PET scan of this particular patient.
Okay.
On PET scan.
Ask Mary, why do you, is it because of the lymph node, or is it because of the lesion in the rectal sigmoid junction?
Sir, the whole idea was to rule out any other metastatic lesions and lymph nodes to find out if this was how do we approach it in terms of resectability or otherwise.
That's interesting. Okay, yeah.
And on PET scan, there were metabolically active lesions of the colon and rectum that were representing biopsy-proven malignant neoplasms, but it was negative for any hepatic, pulmonary, or bony metastasis. At this point, we went for staging of our tumor of the rectal cancer. And as per NCCN, our stage was coming out to be T2, which was the tumor invading the muscularis papaya, and N1, where 2 or 3 regional lymph nodes were identified. And our stage was coming out to be stage 3A as per NCCN. So our next step was, if I may ask everyone present. Anything else that anyone thinks we should have done at this point?
So I guess the real question is whether we give neoadjuvant therapy in some way to the rectal lesion. And that's what we should be addressing. What's the opinion, everyone?
just looking at the scan, is it not resectable, all the lesion that you, from the staging scan, except for the lymph node, obviously, but certainly from the mesorectal point of view, would you consider surgery for this patient?
I was looking at just the CT scan, the descending colon looked very inflamed. I'd be quite concerned about that in terms of what's going to happen with that. So in my mind, I'm thinking the rectal cancer, if the CRM is clear, you'd be thinking that's resectable. And with 3 lesions, I'm thinking maybe subtotal colectomy or pan-proctocolectomy.
I'm still fascinated by that stricturing lesion in the descending colon. I think we need, if I got the opportunity, in my practice, I probably will do a repeat biopsy because I still think this is malignant until proven otherwise. I'm not sure what the Pakistan surgeon thinks about this.
Okay, so we ultimately waited for the biopsy that we had sent when we did our EUA, and the lesion on that biopsy came out to feature Kaposi sarcoma, which was positive for ERG, and it was focally positive for HHV8, the herpes virus 8.
So this was a different diagnosis from the past biopsy.
Yes, sir.
Yes, exactly.
This was the one that we did from our examination under anesthesia biopsy.
Okay.
From the
Same
rectal
lesion.
sigmoid, from the rectal sigmoid junction, 15 centimeter. Is that right? Is that
No, sir. When we did our examination under biopsy, when we did our examination under anesthesia, I'm wondering. When we did our examination under anesthesia, we saw a mucosal abnormality which was arising 3 centimeters from the anal verge, and that is the biopsy that we took.
Oh, right. Okay, additional
I'm sorry. Yes.
Oh, wow.
This one, sir.
But
If I may share.
But you did a sigmoidoscopy before, though, wasn't it?
Yeah, we did. We did, and so the first thing was when we did the sigmoidoscopy, that biopsy came out to be moderately differentiated adenocarcinoma.
It is, isn't it? Yeah.
Yes, and then so when I shared my MRI image, the red star, if you can see.
Yes.
This raised another question for us because this was a thickening along the lateral wall as well. So we decided to go for examination under anesthesia, and we found this. So we found a mucosal irregularity, which was at 3 centimeters from the anal verge. And this was the biopsy that we took out. And this biopsy.
So that's very interesting.
Yeah. You couldn't examine the patient.
So Marine, just to be absolutely clear, this person had adenocarcinoma of the rectum, one lesion, which was another carcinoma in ascending colon, and a third cancer, which was Kaposi sarcoma.
Yes, sir.
And the fourth stricture, suspicious stricture, and the descending colon as well, which we haven't addressed yet.
Which was not re-biopsy.
Yes.
Which was not re-biopsy.
Okay, now it's clear.
Thank you for that. Thank you.
Did we check HIV status?
Yes, sir. So moving forward, I would really like to ask, how would anyone approach this case before I go further, if that's okay?
I think HIV, isn't it? And then I have to go back to the social history, but you told me he's not, if I hear it correctly, homosexual.
Yes, sir. He denied that.
In the Muslim country, for me, it's just mind-blowing. I can't believe this. I can't believe this. This is happening in Pakistan. I can't believe he's HIV.
There are lots of HIV.
Oh, is it? Okay.
We have a significant population with HIV.
Okay.
Obviously, nobody will give history of homosexuality.
Yes.
But I mean, it does not mean it does not exist.
Okay. Right. Thank you.
Okay, so again, we discussed with our tumor board, and we plan to send HIV serology, which came out to be non-reactive. So again, now what do we do? I am really curious to know what everyone would be thinking at this point.
I think, Marine, as Mr. Bajwa has said, that we need to see that whether there is no distant metastasis, patient is fit for an operation. Of course, for these type of multiple malignancies, the options you are left with is panproctocolectomy or subtotal colectomy to take the tumors out if they are resectable. This would be my answer.
It can be, okay, it can be subtotal, can it? Because
because of the rectum panproctocolectomy.
Yeah, it's quite low down. If I hear Marion it's 3 centimeters or 4 centimeters for anal verge. So yeah, I think it's a panproctal, isn't it? It's a difficult one. You may want to do a ELAP here.
Panproctal with ELAP.
Yeah, with ELAP. I don't know how Kaposi sarcoma spread in the lower rectum. I think we got to be really aggressive in terms of surgical management.
Thank you for your comments, sir. So in terms of NCCN guidelines for Kaposi sarcoma, there is advanced cutaneous, oral, visceral, or nodal disease, and our disease, as far as my understanding went, goes into visceral disease. Now, either the patient would be eligible for systemic therapy or patients would not be eligible for systemic therapy. And even in that, you have therapy which is for patients with HIV, who you can put on antiretroviral therapy, or you might have to go for radiotherapy. Now, so in terms of the issue with our patient was that it was not just the Kaposi's that we needed to address, we had to address our other lesions as well. But just for knowledge purposes, the staging for Kaposi sarcoma is either it's good Kaposi's or it's poor Kaposi's, and gastrointestinal Kaposi's comes under poor Kaposi's. So we again discussed in our tumor board meeting for the further plan, and the consensus was that resection is preferable for multifocal colorectal carcinomas. But in terms of surgical options, we either had a total we could either go for a total proctocolectomy, after which we send a patient for radiotherapy and then later do an ileoanal anastomosis to preserve the sphincter function, or we go for an abdominoperennial resection with total colectomy and make a permanent ileostomy. Our surgical team had concerns regarding the loss to follow-up and the effects of radiotherapy on the residual anal stem and later on the repercussions of anastomosis. So what does everyone think now?
I think you have already suggested the thing should be to go for surgery.
Yeah, with the panproctal, isn't it? Yeah. I think probably is the right option in this particular case. Yeah.
And proctocolectomy.
But I think because of the surgeons had the reservation that the patient might not follow up in the clinic, so they must have gone with APR.
Yeah, I agree. Panprocto with ELAP.
ELAP, yeah. Okay. Yeah.
So Marine, what did you do?
We first sat down with the patient and their family, and we counseled them regarding their options, that they could either go for sphincter preserving radiotherapy and later on another surgery, or go
Is it muting? Can't hear.
Yeah, I can't hear you, Marine. We lost you. We can see your slide.
Are you muting? Yeah.
Marine, have you muted yourself? Please unmute.
I think we've lost her.
It's a
Dr.
fascinating
Vidya,
case.
meanwhile, there are some interesting comments in the comment section if you can go.
Okay, right, let's have a look. Yes. Okay. Okay. Is the I noticed this mention about neoadjuvant treatment? Is it for Kaposi or is it for the moderately differentiated adenocarcinoma? Just wonder what people think. Neoadjuvant in the context of Kaposi or for?
It's Dr. Ataullah Mahar. I think it must be in context of rectal cancer, if I'm correct.
But it's a T2 lesion. I thought the staging. So,
My apologies, everyone. I am back.
Okay, so you did the expression.
Yes, there were multiple lymph nodes in the mesocolon, and there were no visceral or mental or peritoneal mets and no ascites. So we are still waiting on the pathological histopathology. It's still not with us. But in terms of some literature review that I was able to do, so for synchronous colorectal cancer, there is a lot of controversy in whether we should go for regional resections versus extensive resections, where there was the study done in Seoul, Korea, which they did advocate for extensive resection to be recommended as a safe treatment option, especially if there's a chance of advanced metachronous cancer later on. However, regional resection is still preferred in terms of decreased risk of complications and of quality of life later moving forward. In terms of gastrointestinal Kaposi sarcoma, so this paper was a nationwide SEER-based study. It was a retrospective study where they were able to attain data of about a total of 685 patients with gastrointestinal Kaposi sarcoma. And they showed that luminal gastrointestinal Kaposis was more frequent than solid organ involvement. Particular issue with this paper was that they did not specify if they were including only HIV positive patients or non-HIV positive patients as well. That was not mentioned. However, they did show that there was a better outcome in quality of life, better outcome in terms of large bowel or anal canal Kaposi sarcoma. But the treatment that they gave here was radiotherapy or chemotherapy. There's hardly, even despite extensive literature search, there are hardly any cases for Kaposi sarcoma in non-HIV patients. I found one case report of an Italian team who reported a classic Kaposi sarcoma with an initial solitary colon lesion. This patient had initially was undergoing treatment for Steven Johnson's reaction, so she was on some steroids. She was scoped for, she underwent a colonoscopy which just showed a small purple nodule in the transverse colon that came out to be Kaposi's. And later on, after 3 or 4 months, the patient presented with cutaneous lesions as well. But this was a case where this patient was non-HIV and she did not have any cutaneous lesions at the time of presentation. Apart from that, Kaposi sarcoma is mostly associated with human herpes virus 8, and it can be seen in patients who are severely immune suppressed. So it does not necessarily mean that they have to be HIV positive. This was a paper presented where a patient was on, a patient was a diagnosed case of ulcerative colitis who was refractory to medical management, and he presented with chronic diarrhea, for which they did a colonoscopy and found a new rectal tumor. And upon immunohistochemistry, he was diagnosed with Kaposi sarcoma. So this was a case of iatrogenic Kaposi's. And with this, I do end my presentation. Thank you so much, everyone, for your time.
Thank you, Mehreen, for the presentation. Any comments or questions?
Marion, I'm not sure whether you can help me here. What does it look like at the time when you operate on this patient, when you open the specimen, or are you allowed to open the specimen to tell us what it looks like for Kaposi sarcoma of the lower rectum? What is the appearance? Is it classical Kaposi sarcoma that you can see on the internet, you know, kind of nodular type appearance?
Sir, I will, I don't know. I'm sorry, but I won't be able to help you here. I wish the operating surgeon was with me right now. That they would better be able to answer this question.
Yeah.
But in as far as variants of Kaposi sarcoma go, the classic variant is the one which is most common, even in terms of gastrointestinal Kaposi sarcoma. So if I have to bet on it, I'm hoping it's that.
Dr. Hakim has two questions, a question about repeat HIV serology and panels thinking about blood immunology secondary to transfusion. So probably HIV was not repeated.
Correct, sir. HIV was not
And
repeated.
second question, Hakim, I don't understand what exactly. Are you saying because of repeated transfusions, this person could have HIV? That's what you're saying. Okay. I'm not aware of transfusion leading to cancers. I am aware of transfusions leading to immune suppressions with the possibility of increased metastases in colorectal cases. So from that perspective, that's my opinion.
Yeah, it will be Hasnain quite unusual, isn't it, to get Kaposi, because we have lots of patients here with repeated transfusion. This is a fascinating case. Thank you very much, Marion. This is learning so much from this presentation.
So Professor Wong, there's another question, rationale of doing a PET scan in this case.
Yeah. I suppose the reason, as I think I asked that question early on, the PET scan probably just to see whether there's a diffuse lymph node metastases, isn't it? Because of synchronous lesions. I was surprised that PET scan is done in Pakistan. I thought you had resource implication, but this is, it's really helpful. Yeah.
So, Marion, thank you very much for the case. This group would be very interested to know the biopsy of the third lesion, which came out as negative initially. Was that cancer or just inflammation? Madia, over to you now. And we have limited time, so the second presenter has to be very agile.
Okay, so our second presenter is Mr. Usman. He's also a fellow in surgical oncology at a private hospital. Mr. Usman, can you please start your presentation?
Yeah, sure. I am just sharing my screen. Actually, someone is sharing his screen. Dr. Puram.
If someone else is sharing their screen, kindly unshare it so Usman can share his screen.
Bismillahirrahmanirrahim. I hope everyone can hear me.
Yes, we can hear you, Usman.
Yeah.
Yes.
Basically, I am presenting. I am Dr. Usman, Surgical Oncology Fellow at Cancer Foundation Hospital, Karachi, Pakistan. Hereby, I am sharing a case of a colon cancer with a splenic flexure mass. The reason of putting a simple case here is to share our experience to operate on such patients in a low affordability areas, as well as to make it more costable to the patients. So here I am starting with my case presentation. We have 62-year-old male with no prior addictions and no previous comorbs, presented to us with shortness of breath, generalized weakness, and undocumented weight loss during the last 4 months. So his repeat hemoglobin check at various hospitals come out to be between 6 and 7. So he underwent multiple blood transfusions outside our hospital. So we examined him and dig out the history from him. He hasn't given any history of fever, hematochezia, altered bowel habits, or melena. So gentleman was well oriented in time, place, and person with the ECOG of 1, vitally stable with a BMI of 22.1. His abdominal examination and DRE were unremarkable with no mass or anything palpable. On DRE, the finger was not stained with any blood or any other abnormality. So we got a suspicion because of his age and the weight loss and the anemia of some malignancy. We sent his stool for occult blood, and unfortunately that came out positive. So we planned a colonoscopy for him, and that showed an ulcerated polypoidal growth at splenic flexure, and biopsy of which came out to be moderately differentiated infiltrating adenocarcinoma. So we went for the CT chest, abdomen, and pelvis with IV contrast and oral contrast. Hereby I am sharing his pictures of the CT scan. This was the axial view of his CT scan, and here I am pointing the lesion at the splenic flexure, the circumferential thickening, and some pericolic fat stranding as well. And the proximal gut was dilated. There were a few sub-centimeter nodes documented on the CT scan report. These were the coronal views of the CT scan. Here you can appreciate the lesion at the splenic flexure, also involving the distal transverse colon. So we also sent a CEA level, which came out to be 6.29, and there were no visceral or any peritoneal disease on the chest CT. So his clinical stage was T3N1M0. Here I'm emphasizing that how we can reduce the cost of our patients. First of all, we admitted the patient on the day of surgery with the advice of bowel prep that started 2 days back at home. Then we took the patient on the same day of admission for surgery, and we underwent laparoscopy, extended right hemicolectomy with extracorporeal high ligation and hand-sewn ileocolic anastomosis. So the intraoperative findings were, there were no ascites, no visceral or peritoneal disease. There was a localized mass of distal transverse colon and splenic flexure with no infiltration into the surrounding structures. And there was no obvious perforation at the site of mass. Hereby I'm sharing the post-op specimen picture of my patient. So this was the terminal ileum. This is the ascending colon, transverse colon omentum, and this was the mass involving the splenic flexure as well as the distal transverse colon. So I summarized the operative steps that we took for him. First of all, the patient position, we made the supine position with both arms by side of patient with placement of sandbag under the right flank area, and secured our patient at chest and thigh level. We usually play the ports in this manner. Usually the subumbilical, infraumbilical port of 10 mm, and at the same level on the left flank area of 10 mm size. Along with that, we usually place 2 other working ports in an arc with the midline port and another port on the contralateral side. So we did medial to lateral mobilization of the ascending colon, hepatic flexure mobilization, mobilization of the transverse colon by incising the omentum, mobilization of the splenic flexure, and lateral mobilization of the descending colon. This is the next step we did is usually not done in the higher centers or in the cost-paying centers. We did intracorporeal transection of the distal ileum, but by first closing the lumens of proximal distal end using silk 2O by doing an intracorporeal suturing instead of using endostaplers. And then we give upper midline abdominal incision approximately 5 centimeter, followed by Alexis wound protector insertion. And then we did extracorporeal high ligation of the ileocolic, middle colic, and left colic arteries to make our yield best for the oncological purposes. Then we did the transection of the descending colon using the linear staplers, and the specimen was delivered as I previously shown to you. We did the ileocolic anastomosis in side-to-side manner in double layer with an inner layer using the Vicryl 3O and outer layer by Prolene 4O. Then to relieve the pain postoperatively, we used to give retrorectus sheet block by making a mixture with Xylocaine, bupivacaine, and with distilled water. Then we did the pelvic train placement and closed the rectus sheath with Vicryl 2, and also closed the 10 mm port sides with the Vicryl 2. So this was the postoperative course of our patient. We kept him in HDU for 1 day, ambulated him on the first post-op day. We removed the NG on the first post-op day and allowed oral liquids. We stopped the medications, IV medications on third postoperative day and removed the catheter and abdominal drain on third post-op day. We discharged him on the third day on oral painkillers with antiemetics and full liquid diets with advice to follow us on fifth post-op day. So this was the histopathology report of our patient, and that came out to be moderately differentiated adenocarcinoma. And it was involving the transverse colon with pericolic fat involvement with no serosal invasion. That was PT3. And the margins, proximal, distal, and the serum margins were clear. There was no vascular or perineural invasion, and lymph node was positive. So the pathological staging was T3N1M0. And we referred him to the medical oncologist for adjuvant chemotherapy. So the reason this was our case, I had two reasons for presenting this case. I know this is a normal case for a colorectal surgeon. First of all, I want to ask that is it preferable to do a left hemicolectomy in such patients, or we have to go for extended right hemicolectomy? Because as we know that in extended right hemicolectomy, we usually take out distal ileum, and patients can underwent into multiple vitamin deficiencies. Along with that, as we had removed the 2/3 of the colon of the patient, and patient can have a complaints of frequent bowel and those complications, you know very well. So from experts, I want to take the opinion in our case, should we have to go for left hemicolectomy, or we have done the great thing?
I think before the panelists answer this question, I think being a beginning in my career, I think this is a very debatable question. This is a very exam question that you have put forward, because splenic flexure tumor, we know that they can be managed in by extended right hemi, segmental colectomy, and left hemicolectomy. Most of the surgeons have a tendency to do in an emergency cases as an extended right hemicolectomy to alleviate the obstruction proximal to it. It's a very valid option. Yes, the points that you have mentioned here, that if you do an ileocecal valve dissection, then it means that you are taking out the valve, you're taking some terminal ileum as well, and there may be problem with the bowel functions. But yes, in an elective settings, most of the surgeons and also the books say that even the segmental colectomy, not the left hemicolectomy, even the segmental colectomy can give you enough lymph nodes and is the procedure of a choice in doing in an elective settings, segmental colectomy or a left hemicolectomy. This is my say.
My comment would be the problem with doing a left hemicolectomy is whether you can do an anastomosis, because looking at the CT, that patient looked obstructed. I would also query the need for bowel prep. I'm not quite sure why you would give bowel prep if you're doing an ileal sigmoid resection, anastomosis rather. And so in my practice, I would probably be thinking about doing a left hemicolectomy, forming a stoma, and reversing that after 6 months. And the key thing is that I think long term, the bowel function will be a lot better.
Okay, thank you.
So I have done both. I think I agree totally with what Adil just said. I think the age of the patient is important in managing this patient and comorbidity as well. He's 62 and he's young. I think we should give him the best chance of oncological clearance. Probably extended right hemicolectomy is what I would do here. But in the elderly, if let's say they're 82 years old, 90, the comorbidity of doing extended right hemicolectomy is really significant. So I've done the left hemicolectomy for that group of patients. So I tend to be quite selective. I wouldn't just say splenic flexure equate to extended right hemicolectomy, although I think they give you a better oncological outcome, but I'm not so sure it's better for older patients. I want to ask Osman, what's the most difficult part of the operation when you do the extended right hemicolectomy in this particular case? What take you the longest time, and how do you deal with that?
And the most difficult part which we faced during the laparoscopy is the ligation part, because
but you did it extracorporeal, I thought.
Yeah, we did the extracorporeal ligation of the vessels.
So, because I was looking at your port insertion, most of them is on the right, left-hand side. If you're going to mobilize the splenic flexure, I just thought you're going to struggle quite a lot. Most of your ports are in the left-hand side, isn't it?
Yeah, we have an optional port that we can place if we face any difficulty in the right iliac fossa side.
But this particular port site is just a bit unusual unless you have tilt the patient, as you said early on, you have an extreme tilt, but I wasn't too sure what do you mean by that. What do you mean by extreme tilt? Are you tilting the patient towards?
Extreme, sorry, I couldn't get you.
You say there's an extreme of tilts are used in your presentation there. Extremes of tilt in your top paragraph there, you say extremes of tilt are used. You're using a belt to secure the patient.
Yeah, I think we were extreme tilt positions. Yeah, I was talking about the extreme Trendelenburg and the reverse Trendelenburg position.
Yeah, I mean, I have used this kind of port insertion before. When I do this, I actually tilt the patient laterally, right lateral. So that port is fantastic for extreme tilt onto the right-hand side of the patient. It's more like a lateral.
We also tilted our patient towards the left side, means the right side is up during the operation.
Yeah, that will be a fantastic way to mobilize the splenic flexure. So I was just wondering whether you did the right lateral tilt in such a way that, you know, the splenic flexure and the transverse colon, because of gravity, helps the traction.
Exactly. We did that intraoperatively, yeah.
Yeah.
Yes, sorry, can I just interject? Dr. Ling. I'm Abid Jamal, and Usman is working with me. So for the splenic flexure, when we are doing a left colectomy, the ports are on the left side, on the right side of the abdomen, and then we put a utility port in the left mid abdomen, sort of. So in this particular case, I think if I remember correctly, we switched the camera ports between the umbilicus and the right half and the right 10 millimeter port. So we start off with the umbilical port for our camera, and then we switch to the left abdomen 10 millimeter port in the middle of that arc of ports. So when we approach the splenic flexure, then again, I switch positions. I get the patient in extreme head up and start working on the left colon, the descending colon, and the splenic flexure while standing on the right side. So I usually try to work with the right port and maybe one port, one hand on the left side. So it becomes a little awkward, but I never hesitate to put additional 5 millimeter ports. I can't remember, I think Usman remembers it better than I do, but I can't remember what we did in this particular case. Now, the difficult part is that at least I prefer now to just do all high ligations extracorporeally unless it's easy, but I do not, and I don't want to struggle intracorporeally trying to get high, because sometimes you get into mishap with the superior mesenteric vein if you're trying to get high, and I don't want to take that chance. So so that's why, you know, I prefer to do that. And the tricky gastrocolic vein, sometimes you get into trouble with that. So I try to do all of that extracorporeally.
Yeah, thank you. So can I ask how long it takes you to do that particular case?
I think this takes us typically, if it's a straight right colon, and it's usually the intracorporeal part is about 2 hours, and the extracorporeal take parts another half an hour, 45 minutes. But in this particular case, I think it took us about 4 hours.
Okay, yeah. I mean, the saving grace for this patient is his BMI is only 22, which is great. I just wonder how much you're going to struggle if the BMI is 40 or 50. I just wonder, I think Adil has already started doing the robotic procedure with intracorporeal anastomosis. Well, they are starting now, as far as I know. I wonder how Adil feel doing the whole operation robotically with intracorporeal anastomosis.
I mean, the key thing about robotic is obviously the stitching is easy. I mean, laparoscopic stitching is, I find, very difficult. So not many surgeons in the UK would be proficient in laparoscopic stitching. Robotic obviously changes that, but you obviously go with what you can, what's available. And doing a high ligation extracorporeal, that's fine. Even laparoscopically, I think often we would take the middle colic, particularly the middle colic vessels. They can be very tricky to take laparoscopically. And you're right, if there's a mishap, then if you're bleeding from the portal venous system, then things can really snowball out of control.
Asif, you have a question to ask?
Usman, it's a very nice and very informative presentation for a normal type of cases, and it's really been something new, not new exactly, very informative. One thing I just want to know that as you do the vascular control extracorporeally, and before getting this vascular control, medial to lateral dissection, is it okay? Is it comfortable? And I mean, by just without doing the vascular control, can the medial to lateral dissection can be done easily first? Second thing, which I get the message that while doing extracorporeal ligations of these vessels like ileocolic, middle colic really makes a little bit trouble. Some registrar vein makes bleeding and something like that. So is it very comfortable for you when you just do the extracorporeal ligations, does it make any less problematic or not? That's I want to know.
Dr. Asif, do you mind if I answer that? Because Usman has been with me only for this. This is his 5th month, so it may not be fair for him to answer. Okay. So, Dr. Asif, I think that once you divide, once I would divide the terminal ileum between ligatures, not sutures, as he said. So in order to save an endo-GI firing, we will put number 2 silk ligatures on a window we make in the terminal ileum, and for control, and keep one long, the other end short for marking it, and divide the terminal ileum. Then we work our way into the mesentery, and I will stop short of the ileocolic vein. If it's very easy and I can gingerly move forward and get all the way to the SMV, then I will do it. Otherwise, I won't do it. Then I would just go to the hepatic flexure, work it off the duodenum completely, and carefully trying not to get into the big vein that comes off the anterior surface of the pancreas, and take that down. So those are the maneuvers I would do. And if it's very easy, I might just ligate it. What I've noticed is that a lot of people, in order to steer away from the superior mesenteric vein, and they would not do a high ligation, and they would do a high ligation close to the mesentery, which would defeat the purpose of getting a good node harvest.
Right. Thanks, Abid. Nice. Thank you so much.
Usman, sorry, the very nice presentation. The only thing that I was interested is, because I know the meaning was to tell us the cost-effective way of doing the resections. And the fecal, the contamination is always a fear. Do you think that these techniques, by doing the tying and suturing the resected end and not using the J-stapler, can lead to more contamination? This is the one thing that I would like to ask. And more importantly, why can't you take the entire, because bowel is all mobilized, why don't you just resect once the entire specimen is in the wound, and then resecting it through the 2 staplers?
Okay, so Sabah, Usman just stepped out. So let me just answer that again for you. Okay, so yes, that's a valid point. When you do a ligation and just divide, then what we also do, we have these little tricks that we try and do, is we slip in a pyridine soaked gauze into the abdomen, and we just use it to dab it a little bit and keep it clean. Yes, that does introduce a bit of contamination, but not too much. Extracting the undivided terminal ileum is a little bit more difficult than if you divide it and you free up a bit of the mesentery. Then you can slowly extract it out of the alexis with a smaller incision. If you don't do that, then bringing out a loop of bowel, instead the bringing out an end of a divided loop of bowel, divided bowel, is easier. And I think the other consultants, the other surgeons here would endorse that it's better to divide it and then extract it out from the divided end, than to bring the undivided. That can be done, but I think it's easier. That's why I do it.
I think the contamination bits worries me a little bit, Jamal, because you give them bowel prep the day before surgery. I don't know what the bowel prep is like. We here in England, we have to ask them to drink lots of water to clean them out. Would it not cause a lot of contamination in some cases?
I can understand what you're saying, and I don't think we've regretted it so far, where we've had an awful lot of contamination because the ligatures are in place. We have a sucker down, and so yes, there is contamination. I have to give you that much, but it's not too bad. Regarding bowel prep, I've wavered about not giving them bowel prep, but in the balance, I've decided to give everybody a 2-day bowel prep, like I would for a colonoscopy. A first day of full liquids, second day of clear liquids. We don't use any luminal antibiotics, but we do pre-op antibiotics all the time. But I'm an old dog, and they've been unable to teach me new tricks. So I'm still going to
thank you, Abid. Dr. Ali Haider has raised hand. Our time is almost up, so Dr. Ali Haider, a very quick question, and then we will wrap up.
Thank you, Dr. Hussain, for providing me this opportunity to ask a question. Very informative case, and I find Dr. Abid Jamal's strategy in our lower source country very attractive and very very optimal for the patients that we get in our public sector hospital. Moreover, I was concerned. Usman mentioned that he was concerned regarding he coined a question that by doing extended right hemicolectomy, we would be excising a lot of terminal ileum that may cause absorptive difficulties for the patient as well. I was concerned about this particular case. Dr. Abid, would you like to answer that? How much terminal ileum would you rejected in this particular case with doing extended right hemicolectomy for sigmoid mass? Moreover, another question would be that what incision did you use for specimen retrieval, and did you sew the hand-sewn anastomosis through the same incision, and where did you place it in the abdomen exactly?
Okay, so we just take about 7-8 centimeters. We don't take a lot, actually. I think Usman exaggerated that a little bit. So the hand-sewn anastomosis is very comfortably done outside and the incision is usually 5-6 centimeters for not the smallest lexus, but the next to that, the second size lexus from bottom up.
Okay, thank you.
Thank you, Abid, for the response. I think I see two more participants have raised hands. Hakeem, very brief question.
Can somebody hear me?
Yes, everybody
Yes,
can.
please.
Yes. So I know there's always a controversy about splenic flexure tumors. There has been large studies, especially NESCIP ACS American studies, which have suggested that segmental splenic flexure colectomy has an equal outcome with good harvest of lymph nodes. What does the panel think about it? And the second question is, can we implement this kind of resection with a scintigraphy, lymphatic scintigraphy?
Professor Wong.
My general view about this segmental or extended right hemicolectomy, I think we really, this day and age, we need to take a pragmatic approach. I don't think one size fits all. We got to be very selective what we can offer to the best for our patient. My view is, I think if you want to think about curative intent for a younger patient, I think the extended right hemicolectomy is something I opt for, but really for other patients, I use my judgment accordingly. Lymphatic scintigraphy, I have not much experience. I'm not sure Adil can comment on this.
Yeah, I mean, some centers will use a Firefly that inject ICG close to the tumor, mainly for rectal cancers, but I don't think there's much application in colonic cancer. It's not very accurate.
I think, Adil, you do that routinely, isn't it, for your rectal cancer surgery? The leak rate, as an observer, I think it's still pretty much the same as your eyeball.
Yeah, I mean, the ICG we use for vascularity, but some people would use it for lymph nodes as well.
Okay, thank you very much. With this, we come to end of our meeting. Thank you, Professor Wong and Adil, for joining us today and enlightening us. It was wonderful hearing from you. Thank you, Sabah, for helping us organize this and being our ambassador in UK. and rest of the participants for very nice presentations. We had few more. I wish we could have done them, but we look forward to further interactions in future also.
Thank you so much, Hasnain. Thank you, Marine. Thank you, Osman. You blew me away with this Kaposi sarcoma today. I put my head in shame, not knowing too much about how to manage Kaposi. But thank you, everybody.
Thank you. Assalamu alaikum.
Thank you. Okay. See you next time, inshallah.